Bonjour à tous et bienvenue.
Good afternoon, everyone. Welcome. I suppose most interested people are now in the room, so let's start this session. As I said, welcome to this Educate conference on health and education. This session will talk about the collective action for readaptation. I am going to come back on the Educate platform definition. I just want to tell you this connection is organized by Educate, but also with VVOB and APFE animating this session today. So this is part of the program, and this will allow us to get back on the relationship between health and education, as we could see in the keynote speech this morning. My name is Clément Bagnois. I am health and rehabilitation expert for the APFE Burkina Faso. And in this conference, I will take the floor with four people. Dr. Jean de Dieu, we have Patrick Willem, we have Fadzela Liponis, and we have Sister Dembele. They will talk to you about the relationship between health and education, focusing on readaptation. As you know, the WTO during the last General Assembly focused on readaptation. Readaptation should be integrated in health systems, and that supposes human resources that we don't have now. And this also leads us to the question of training those human resources. This session will be in French. We will listen to the several speakers. We would like to remain in the timing, the time allotted, as this will be relatively short. Questions will also be in the chat. My colleague will take note. And as a conclusion, let me tell you that this session is coordinated by Alexia Germo, our health and readaptation manager. Without any further ado, I will now leave the floor to the first speaker on my left, Dr. Jean de Dieu Avriarimana, Director of the National Integrated Program for the Prevention and Control of Non-Communicable Chronic Diseases in Burundi. And he has a long expertise in readaptation systems. So he will start this panel. Thank you very much.
Oh, je vais utiliser l'écran là-bas. Je crois ici que ça ne marche pas. Bonjour à tout le monde.
So good morning, everyone. Good afternoon, sorry, everybody. My name is Jean-Dieu Avriyamana. I am director of the National Program for Non-Communicable Disease in Ministry of Health in Burundi, and we work with our partner APFE. Let me just share with you some reflections on how we integrated readaptation in our health system. All right, I am the one who needs to click. So, readaptation. No, you need to speak in the microphone, sir, otherwise we cannot hear you.
Ah, ok, là c'est bon. Donc, la réadaptation, c'est un droit
So,
fondamental de la santé.
readaptation is a healthcare fundamental right. It is embedded in a healthcare continuum.
Ah, il y a quelque chose. Donc, c'est pas grave. Donc, je disais qu'elle est inscrite dans le continuum de
So, it
soins.
is embedded in a healthcare continuum with prevention, diagnosis, curing, and palliative care, and it is also for people with disabilities. What is the problem with it now? According to the WHO, 2.4 billion people have a need for readaptation care in the world, but unfortunately, only a minority gets access to those care. Therefore, as players, what can we do? We can strengthen readaptation in our health system, basing ourselves on the WTO strategy. So the Readaptation 2030 of the WHO. Let me share with you the highlights of this strategy, i.e. strengthening the 6 pillars of readaptation in health systems. It is about governance and leadership. Second, financing supply and demand. Third, developing human resources. Fourth, infrastructure and care network. Fifth, development of health information and research, and access to technical aids like prosthesis, orthesis, and so on, prosthetic, orthostatic, and so on. What is the experience of Burundi? Since 2011, Burundi is developing and implementing a program to support the development of physical and readaptation medicine in order to reintegrate this into our healthcare system. This project, this program, so to speak, is a three-part program. We have Belgian partners like APF and the Belgian governments who give us the expertise in financial and technical system, and the Ministry of Health, and also the COPED, civil society in Burundi, that makes it possible to have a technical support and some flexibility. There are also other partners. There are notably the Catholic University of Louvain and the University of Benin, also the Brussels Free University, cooperation with ARES, and the University of Hasselt in cooperation with yet another partner. So what is the strategy for this program, Physical Medicine and Readaptation? It is a long-term change for about 20 years based on the first 5 pillars that I showed you. And these are the 5 that you can see here on the screen. The 6th one being the access to technical aid. But we focused mainly on human resources training in our project, without forgetting, of course, the other pillars I'm showing you. The third pillar is the catalyst of our readaptation program. Why is it so? Well, you will see. What are the human resources that we have reinforced? There are many, and we focused mainly on physiotherapists. because they are the most numerous amongst this readaptation professions. But in 2011, when we started, we only had 5 physiotherapists. So there were a real need when it comes to human resources there. And there was also the need to have other type of professions. Maybe they will be developed afterwards, but we mainly focus, as I said, on physiotherapists. What is the procedures that we followed? It's a 4-step. First, from 2008, we started training 14 physiotherapists. They were sent to Benin. They were selected amongst the best of secondary school. They were sent to physiotherapy school in Benin. This was created with the University of Louvain. And amongst these 14, 6 are working, are doing a PhD in one of the universities, Louvain, Brussels, or Hasselt, or even China. Second, in 2016, we started a national reference center for rehabilitation and physiotherapy. It is at the hospital of Bujumbura, and it is done by the physiotherapist trained in Benin, and the management is given to COPED. So there's a private-public partnership. We are treating 100 patients a day. And in it, you have continuous training. You have notably trainees. Et donc, so we created in 2019 a physiotherapy school under the auspices of the Ministry of Health. So they are training health HR. So this was done in cooperation with the Louvain Catholic University, and the training center, CNRKR, is working in training different candidates. We have about 20 students, and we have so far 76 graduated. 29 female, 47 male. And for 90% have found a job. We are also organizing continuous training there. We developed a national network of physiotherapy services. This is the administrative map of Burundi. We previously only had services that were spread like this. In 2025, we now have 49 services with that spreading. So, of course, Bujumbura being the economic capital is more well deserved.
Quelles sont les réalisations qu'on peut se vanter? C'est que maintenant, on a
So what can we boast about? We now have physiotherapists available. These type of cares are better known by the population. That means that there is an increase, and also hospitals. Hospitals are developing their own physiotherapy services, and health insurance are also reimbursing physiotherapy cares,
le ministère de la Santé publique
so that's more
fournit des
affordable
informations sur
for the
l'activité et les
population.
statistiques ou ces données collectées encouragent le ministère à développer
These
la
data, of
réhabilitation.
course, are very
Donc,
encouraging
quels sont
for the
maintenant les
Ministry
décisions
of
prises
Health
à
for
travers ce
developing
programme?
this type
C'est
of
que
care.
développer la réadaptation
What are the
nécessite
lessons
un long
learned?
terme, je
Developing
vous l'ai déjà dit,
readaptation is
qui est
a
basé sur
long-term
6 piliers,
process based
par
on
l'OMS.
the
Et ce pilier trouve le
WHO
ressources humaines en
defined
priorité
pillars,
parce que
and human
il
resources
stimule
is
le
the
financement du réseau
priority.
de soins,
Why?
le financement
Because
des
it
soins par
stimulates
les
the
centres de
funding
santé,
of the
la recherche
caring network,
d'autres données
the
de
cost
réadaptation par
of
notre
cares
ministère
by health
et les travaux de recherche
insurance,
et réadaptation.
research,
Et
data
donc, une meilleure
research
gouvernance de réadaptation
on
par notre
readaptation
ministère.
by our ministry, and therefore a better governance
Comme
for
conclusion,
our ministry.
l'action sur le pilier formation des ressources
Conclusion.
humaines doit démarrer très tôt.
Actions when it
Elle est
comes to
nécessaire,
training
elle
human
nécessite plutôt
resources
une action
needs to
collective,
start
comme on
very
voit parler
quickly.
d'adaptation
It
aujourd'hui.
requires
Ça, je peux vous
a
partager.
collective
On avait
action.
commencé à un transfert de compétences ci-dessous,
We
Burundi, Bénin,
started a transfer
et on a
of
sélectionné
competence between
l'institution de
Burundi
formation pour
and
accueillir la
Benin,
filière de
and
formation,
we
donc le
selected
CIB de
a
Bujumbura.
training
On a
institute, a health
formé
training
des kinés
institute,
formateurs
the
universitaires.
INSP
On a
Bujumbura.
élaboré un curriculum de
We have a
formation
training
et des
physiotherapist,
missions
master level.
d'enseignement et de formation
We
continue
have
sans
designed a
contradiction
curriculum
avec
of
votre activité
FKR,
actuelle.
and we have
Sixièmement, on
also
a
teaching and continuous
continué par la
training
formation des
missions in
enseignants-chercheurs au
cooperation
niveau
with the
doctorat comme je vous l'ai dit,
University of Louvain.
le
We
développement de la
also have the
recherche et de
training
formation
of
des PhD-ST, et
teachers
tout ça
and
en collaboration
researchers,
avec
i.e.
les autres partenaires
PhD
universitaires,
students,
notamment
and we are developing
l'Université catholique de
research, all
Louvain,
this
l'Université
with
Hasselt,
our different
Bruxelles,
partner
Lille et
university,
Arès.
Louvain,
Euh,
Hasselt, and
donc,
Brussels,
vous voyez que
with Vlier
c'est
and
vraiment
Ares
une
as
action
well.
collective
So as
pour
you
la
can see,
formation.
this is really a
Donc on doit
collective
mutualiser
actions for
les forces
training, and we
en
need
technique
to mutualize our strength.
aussi autour de 20 ans. Je vous remercie.
This will be, as I said, a long-term action that will last for
Merci.
about 20 years,
Merci,
or has taken
docteur
about
Jean
20
de
years.
Dieu.
Thank you very
Docteur
much,
Jean de Dieu
Dr.
qui a
Jean de Dieu.
essayé ici de nous montrer comment,
You
justement,
tried
à
to
travers
show
la
us
formation,
how,
l'éducation des
through
professionnels,
training
nous
and
faisons
professional
arriver à mettre à la
training,
disposition des professionnels en
education,
quantité, mais aussi
we
en
can
qualité,
not only
un
have
réseau de
a
décentralisation des
quantity
soins,
of
mais
professionals, but
finalement,
also
par l'éducation et
qualitative
la formation, on arrive
care.
donc à étendre un réseau de services de
This is how you
toutes les
can
populations
extend a
souffrant
healthcare
à ce sujet.
network to
L'éducation, bien
give
sûr, au
out our
cœur de
population access
la
to
solution.
such
Pour ça,
cares.
passer la parole au
I
professeur
now leave the
Williams,
floor
professeur Williams,
to
professeur
Professor
émérite des
Patrick
sciences
Willems, Professor
cliniques à
Emeritus
l'Université
in Motor
catholique de Louvain.
Science at
Donc,
the
plusieurs projets
Catholic University of
réussis
Louvain.
pour justement
He took
mettre en
part
place
in
des
several
formations,
um,
notamment en Afrique, mais aussi
projects,
en Asie.
notably
Donc,
in
je laisse donc
Africa and
professeur
in
Williams
Asia.
s'entretenir avec nous
So I
sur
now
ces
leave the floor
expériences.
to
Merci.
Professor Williams
Je vous
on
laisse la parole.
these different experience. You now have the floor. Thank you.
Cette dia-là, je vais la passer. Ouais. L'expérience de notre faculté, donc qui s'occupe, qui est en charge de
The
l'enseignement de la
experience
kinésithérapie
of
à
our
l'université de Louvain. Nous
university,
avons une
the
expérience d'environ
faculty
30 ans
teaching
dans
physiotherapy
l'aide et
is
mise en place de
experienced
services de
for
réadaptation
about 30
dans
years
les pays cités ici, le Bénin, le Burundi, le
on
Burkina Faso en Afrique
setting up
et
pre-adaptation
le Vietnam également
system in
en Extrême-Orient.
such countries.
Alors,
So we mentioned several in
c'est quoi en
Africa,
fait
but
le but
also we have also
de se
some in
former
Asia.
en
What's
réadaptation,
the goal to train
d'améliorer la
in
formation,
readaptation
c'est
and
de
to improve
consolider le processus de
training? Well,
réadaptation
the
en
idea
renforçant
is to
les bases
consolidate the
académiques
readaptation
et
process,
il y a une seconde
reinforcing
partie
the
au
academic
relevé qui est la
process, and
consolidation de
also
l'association
consolidating
professionnelle. J'en dirai un tout petit mot
the
là-dessus.
professional
Donc
association. I
parlons
will say
d'abord
a few words on
de
that
renforcement
later.
des capacités
Let's
académiques.
talk about
Le but,
academic capacity
c'est
building.
d'amener la formation en
The goal
kinésithérapie au
is
niveau des normes
to
internationales,
bring
et ceci afin
physiotherapy
que
training at the
les
level
individus
of
puissent
international
jouer le rôle qu'on attend de lui au
standards.
niveau des et ainsi améliorer la qualité de la vie et
in
le
order to
bien-être
improve
des
the
populations
quality
locales.
of life and the well-being
Améliorer
of local populations. So
le niveau de la
improving
formation pour que les physio
training
puissent participer
so
pleinement
that
à
the
l'administration des
physio
soins de santé locales.
can be a
Alors,
part of
au niveau des formations,
healthcare, local
il y a trois niveaux de
healthcare.
formation sur lesquels on peut
There are
intervenir. Il y a la
three levels
formation
of
initiale,
trainings on
qui est
which
donc une
we can
formation qui va
intervene. You have the
amener
initial
les
training
étudiants futurs kinésithérapeutes à
that will
accéder à la
bring
profession de kiné.
the
Il y
student,
a une
they will give
formation
it
plus
access
avancée
to
qui va
um,
viser à
passion. Then there
former
is another one
les personnes
aiming
qui
at
vont
training
enseigner au niveau de la formation initiale et qui
the
permettent également
teachers.
de spécialiser les kinésithérapeutes dans différents domaines de la
And
kinésithérapie.
they will help
Et puis, il y a la
specializing
formation doctorale qui
physiotherapists in
permettre de
several
former les
branches.
enseignants qui
And
vont
then
devoir
there will be the
enseigner
PhD
pendant les
training
enseignants en master et qui va
for
permettre également
training teachers,
de
master
réaliser la
teachers,
recherche et
and
la
also
publication
who will
universelle pour
organize
avoir une
research
visibilité
and
sur la scène
publication
internationale.
to
Et
have
puis, c'est
some
également ces docteurs
visibility
qui vont lancer
internationally.
les
These
écoles. Ça, c'est
doctors will also be able
je
to
dirais le
manage
schéma idéal.
schools. That's the ideal
Alors, si on regarde un petit
scheme,
peu,
so to speak.
si on parle un peu de notre expérience au cours des 30 années,
If we talk
pour
about our
ce qui est du
experience
Bénin,
these last
euh,
30 years
donc il y a une chose qui est
in
différente
Benin,
entre le Bénin, le Burundi, le Burkina
there is
Faso et
something
le Vietnam, c'est que
different between
au Bénin, au
all
Burundi et au
the
Burkina
in
Faso, il n'existait
Benin,
pas
Burundi, and Burkina
de
Faso
formation en
is that there
kinésithérapie
was no
lorsque
training,
nous avons commencé à
physio
travailler avec la
training
Belgique et le
when we
Burundi,
started
alors qu'au
working with
Vietnam, une
APF.
structure existait déjà,
While
mais
in
que
Vietnam there
le
was
niveau
one,
d'enseignement était trop faible.
and but
Il y a une grande
the
différence.
level
On
of
parle pas
education was
de la même ligne de
too
départ
low,
entre
so we
les
don't start from the
capacités.
same baseline.
Alors, la formation, je reviens en arrière. Au Bénin, la formation,
In Benin,
ça a été réalisé par
the
des
training
kinés belges qui sont partis
was
enseigner
made
pendant une ou
by
deux semaines
French
à
physiotherapists
Cotonou.
who
Au
went
Burundi
teaching
et au
for
Burkina
a
Faso,
few weeks in
il y a eu
Cotonou.
l'envoi
In
d'étudiants
Burundi and
de
Burkina
l'ESK
Faso,
à ce moment-là.
they sent
Ça
students to
fonctionnait très bien.
ESK,
Donc,
as
il y a eu une
ESK was
collaboration
working
suivante.
very well,
Et
and there was
au
a
Vietnam, on a
south-south
en fait
cooperation, while
simplement
in
reformé le
Vietnam,
programme de base.
we
C'est une tâche qui
simply
a été confiée
reformed the
à la
basic
World Physiotherapy en
program.
association
This
avec un
was
handicap international.
done with World
Si on parle
Physiotherapy in
maintenant de la formation
cooperation with
avancée,
on Handicap
les
International.
professeurs, au départ,
Now,
les professeurs, c'était des kinés qui avaient été formés en formation initiale et qu'on a amenés en
teachers
Belgique pour réaliser
at
leur master.
first were in advanced
Au
training
Burundi
were sent to
et
Belgium for a
au Burkina
master.
Faso, c'est
In
exactement la même
Burundi
chose.
and Burkina
On a
Faso, it's
envoyé
exactly the same.
des
We send
kinésithérapeutes locaux
local
s'enseigner
physio
en Belgique.
to get trained
Au
in
Vietnam,
Belgium,
on a en fait créé un
while
master
in
avec l'appui de la
Belgium,
RS. On a
we
créé un
create the
master
master
et
with RS.
ce master nous a permis
This master
dans les 5
course
dernières années de former 80
allowed
étudiants.
us to train
Donc
80
en fait,
students these
on a
last
produit,
5
on a
years.
pu sortir beaucoup plus de
So we could
professeurs
graduate
au
much
Vietnam
more,
que dans les autres
many
pays
more
parce qu'on est dans
teachers
d'autres
in
pays, on
Vietnam than
commençait
in
avec une
other
dizaine
countries,
de
because in
masters
other countries
dans
we
chaque pays.
started with just
Et
a dozen
voilà.
master in every country.
Alors, au niveau de la formation doctorale, eh bien, je
Now,
parle
when
ici
it
des kinés qui ont
comes
été
to
formés en
the
Belgique,
PhD, I'm
dans les
talking
AFCO
about
tout plus particulièrement.
the people who were trained
Donc,
in
au
Belgium,
Bénin, nous avons
in
formé 5
the
docteurs
Louvain
en
University.
kinésithérapie. Au Burundi, il y a
We
5
have
docteurs
5
qui sont
PhD in
formés à
Benin.
Bruxelles. Je ne pense pas qu'il y en ait un
In
ici. Et au
Burundi,
Burkina Faso,
we
il y en
had
a un
2,
qui
while
a été
in
formé.
Burkina Faso,
Au
1
Vietnam,
was
on est
trained. In
actuellement, ils ne sont pas encore
Vietnam,
tous sortis, mais on est
well, they are
actuellement
not
dans la
there
formation
yet,
de 7
but we are training
de 7 doctorants. Et
several
en plus, au
students,
Vietnam, on va pouvoir
PhD
créer un
students,
laboratoire de recherche
and in Vietnam we will create a
euh,
research lab
qui, à terme, vers 2035, devrait amener à l'ouverture d'une école
that
doctorale
should
qui va alors
lead
permettre
to the opening
que
of a
l'Église vietnamienne ne
PhD
doive plus
school
s'expatrier pour
so that
délivrer.
Vietnamese students do not have to
Une
expatriate
chose qui est
themselves to
extrêmement importante,
do their
c'est
PhD.
d'inciter
A very
dès le
important
départ
aspect
les
is
populations,
really to
les autorités
invite
académiques et politiques à
population
s'approprier le projet.
to take ownership of
Et
that
ça,
project.
c'est important pour pouvoir
And it
pérenniser
is important
l'action et
to have a sustainable
aller
action.
au-delà du projet. Donc, si on revient un petit peu sur ce qui a été fait au Bénin, il y a
If
un
we come back
faible
to what
leadership
was done in
institutionnel
Benin, there is a weak
et
institutional
au
leadership
niveau également académique, qui fait qu'en
and
fait, parmi les
academic one.
5 docteurs que nous avons formés,
So
aucun de
amongst
ces docteurs
the
n'a été
5
engagé
doctors
pour
that we had,
la
none of
gestion
them was hired
gestion de l'école
for
de kinésithérapie. Au
managing
Burundi,
the
ce qu'on m'a dit, c'est qu'il y a un
physiotherapy
manque
school.
d'institutionnalisation
In
au niveau
Burundi,
des
there is a lack of
trop dépendant de quelques professeurs seulement.
institutionalization. It just depends on some teachers.
Olivier, tu corrigeras.
Olivier, you will correct me if I'm wrong.
Au Burkina Faso,
In Burkina Faso,
c'est le gouvernement qui a demandé à la
it's the government
d'organiser
that had asked
la mise en
APFE
place d'une formation
to
auquel nous avons
start a
été
training,
associés,
physiotherapy training. We were associated to it,
vraiment une volonté d'aboutir.
and there was a
Au
real
Vietnam, les 7
willingness to
docteurs, en fait,
deliver
ont été choisis
results.
parmi
Then
membres
in
du
Vietnam, the 7 PhD
personnel
were chosen amongst the staff members, amongst the teachers there, and when they will be back after their thesis,
ils pourront continuer
they will
former les masters d'une part
keep on
et à
training
gérer l'école d'autre.
master students on the one hand
La deuxième
and
chose
managing
qui
the
est
school on the
importante,
other
c'est
hand.
que
What is also very
en même
important
temps que
is
l'on
that
améliore la formation, il faut également consolider
we
les
are
professions professionnelles parce qu'elles vont devoir jouer un
not
rôle
only
important
training
dans
professionals, but also consolidating
l'intégration dans les
the professional association because it has an important role to play in integrating readaptation in the national strategy.
C'est quelque chose dont l'association peut s'occuper. La
So the
formation, c'est au
association
ministère de la Santé et
can
l'organisation et
care for the
faire en
organization
collaboration avec
um,
les universités. Et je
of
terminerai en disant simplement
continuous training, for example. And let me say
c'est un processus qui est
that
gagnant-gagnant, aussi bien
this
pour les
is a
universités
win-win
du Sud
process, not
qui
only
reçoivent un
for
appui technique,
the
mais
University of the South receiving a
qui
technical
permet de
assistance
créer des
um,
filières plus avancées,
and
qui leur
that
donne une
they
visibilité
can create
scientifique
more
et
advanced
qui permet
curricula.
également
It gives them some scientific
essentiellement pour le
visibility,
Nord,
and it
pour
also helps
l'Université
training
partenaire
the
Nord,
teachers.
c'est une
For
expérience
the University of the North, it's a very
scientifique
enriching
partagée, des ressources
pedagogical
professionnelles
experience,
élargies et
an extended
accès aux
network,
financements et même
and
des
access
enseignants
to
et des
funding
étudiants.
as well
Je
as
terminerai en
mobility
disant
of
simplement que la
teachers.
condition de la
And let me
réussite d'un
tell
projet,
you that
c'est d'abord
for
d'avoir
such a
une vision
project
commune
to
entre
be
l'auteur et
successful
les
is that you need
partenaires
to have a common
et
vision
un intérêt
between the
réciproque.
partners, North and South,
Une
and a common
gouvernance du projet
interest,
qui doit
also
être partagée.
a
Il
shared
faut
governance
également,
of the project
pour pouvoir pérenniser le projet, que
in order for it to be
si possible,
sustainable.
dès le départ,
You
il
need
y ait
from the
un
very
plan de carrière
beginning
pour les gens
to
qui
have
viennent
a career
en
plan
Europe ou
for the people
qui se
coming
forment
to study
de
in
façon plus
Europe
avancée et
that get
qu'il y ait un
trained for moving
leadership
forwards.
institutionnel
And there must be also an
et
institutional
académique fort.
and
Voilà.
academic leadership, institutional and academic leadership, and a strong one.
Merci bien,
Thank you very much for this presentation that follows the very first one and that explains how such a North-South cooperation helped build capacity and developing human resources. We will now leave the floor to two other people. Radzela Liponis, she is a rehabilitation specialist and manager humanity and inclusion. She is in charge of readaptation program in crisis situation. She will share with us concrete example on the ground before moving to the last presentation of Sister Dembele.
Moi, je vais illustrer ici divers exemples de formation professionnelle de la réadaptation.
Trying to illustrate here different vocational training examples, that provide access to training to vulnerable population groups, and I will specify the partnership strategies that have been useful for the accomplishment of these projects. When what we are in a context of acute crisis, to be compared to a chronic crisis or a development crisis, what is going to be different in terms of training strategy and what specifically has to be taken into account? So this is the first cohort of rehabilitation technicians that were trained in Haiti after the earthquake. It's important to know when when we came to Haiti, there were 4,500 amputated people. There were also fractures, skull traumas, with only 6 physiotherapists in the whole country. So we had to provide care, and we have to train our nursing staff so they could perform basic gestures. But the needs were so huge that in the end, we decided to develop a training of rehabilitation technician. The Ministry of Health and the Ministry of Education were affected directly by the earthquake. So in that context, it was not, there was no time for having a northern university come in or have training curricula validated. So we started by training a rehabilitation technician. The role of the rehabilitation technician was in between theory and practice directly in the services and mentoring, because of course they needed support. So that training lasted for 18 months, and we could thus create the first cohort. And then we realized that in the country there were only 6 physiotherapists, but there were all sorts of actors that were trained into other things for training courses of 3 months on the basis of curricula, 3 months curricula, 6 months curricula, huge disparities between the levels of training. So we suggested to the ministry that we should provide a leveling up training so they could all get the 18 months training. Then that was the first phase. Then we mobilized northern universities, and they came to provide more specific training courses. We moved on from caring for traumas to caring for the general needs of the population, and we were able to provide this ongoing training, and we ended up with 56 rehabilitation technicians and orthoprothesis. Now we are still working with the ministry, and we have a program called Bridge, and we're wondering now how to reintegrate these people into a formal training program, and how can this curriculum be recognized? It does exist in Haiti. Now we are mobilizing all sorts of partners, and we are asking them to validate this curriculum, and in order to allow that labor force to be leveled up to the international standards. So even though we were in a crisis situation from the very start, from the very first response, we have to have a long-term vision, formalize the curricula, and keep all the evidence, because it is what the ministries require. So when we speak about emergencies, it's very important to leave some room for preparedness to to emergencies. We are facing a growing number nowadays, a growing number of emergency situations. And we've been working with the WTO. We created contingency stocks, mechanisms of coordination with the ministry. We had a mapping of the services, but we also needed a staff that was trained for providing support in cases of emergencies. That was done in Lebanon in cooperation with the Association of Lebanese Physiotherapists, with the ministry, with the International Red Cross Committee, and we created a pool of clinicians and physiotherapists. When in 2024 there were the attacks in the south of Lebanon, this pool could be mobilized very early to take care of the traumas, to provide care in the framework of the traumas that were caused by this attack. So preparedness can't be neglected. Preparedness to emergencies, to deal with emergencies. Then we can move on to a context of development. And I think Professor Willem showed you in Vietnam what was put in place. We had a context with more than 4,500 physiotherapists in the country, with 6 different levels of curricula and 6 different levels of training. There were titles: physiotherapy, technician, assistant physiotherapist, and so on, and a very broad heterogeneity of the training levels. And so the first stage was to work with the World Physiotherapy Association to carry out an analysis of the needs in cooperation with 4 universities. Once the analysis of the needs confirmed the need to consolidate the curriculum, in Belgium, we have a very high-level network of actors in the field of rehabilitation. We have universities involved. We have actors such as Handicap International, and also a lot of support, funders who support us, donors who support the rehabilitation sector, because that's a very rare situation. And the Catholic University of Leuven told us, well, you are in Vietnam. How can we coordinate with you in order to strengthen, consolidate that initial training? So then we moved on to the definition of the national curriculum, and then we started working with the universities and the authorities, with the National Physiotherapy Association. Because the goal was to level up the training skills. And there were many partners. World Physio helped us. Handicap International continued their work with training courses in the services, in the departments. So to make sure that the acquired know-how was put in practice, and they trained people coming from the provinces. And that continues, and we've reached the master level and PhD level. By working on the basis of complementary fields of competence, we can touch the different levels of training and secure the sustainability and the quality of the overall training level. So what are the recommendations? Well, the first recommendation is that there is not one single training strategy. It's not cut and paste. How can we, through an analysis of the context and the needs, develop the way that better matches the needs? And it also depends on the national strategy. Is the country going to develop the training of occupational therapists? Does the ministry wish for a community level rehabilitation or secondary level rehabilitation? So somehow strengthening the strategy of the ministry enables us to better target the way in which the training will put the focus on certain fields more than others. And the example of Burundi has showed it. Our strategies are long-term, 15 to 20 years. If we want sustainability, stability, we need a commitment of the stakeholders, of the different players in the long run. Coordination and complementarity leads to sustainability and the efficiency of the training levels that are proposed. And the first recommendation is the following. If we want universal access and reach the ODD number 3, sustainable development, beyond the high quality training, we need mechanisms that enable the most vulnerable people to have access to those services, because developing services and training professionals, does it necessarily mean that the most vulnerable population groups will have access to that care? So the component of access to care is key. And the last recommendation, nowadays, when we look at the Sustainable Development Goals, what do they say? They say we should reach well-being for everybody at all ages. But if we look at the indicators of these Sustainable Development Goals, we have morbidity and mortality indicators. So there is a huge gap in that framework. Everybody agrees, and it's true that the WTO have launched their strategy only in 2018. So it was before the discussion about the Sustainable Development Goals. Everybody agrees that today rehabilitation is a key service in the continuum, in the continuity of care from prevention until reintegration. But if we use as a basis the international framework and the Sustainable Development Goals, which are still the reference of the ministries, because it's something they can base their strategy on, there is no functionality indicator. How can we reach everybody's well-being if we don't have an indicator that is an indicator of well-being and that is a specific one? So today, what we're trying to do among the World Rehabilitation Alliance, among others, is saying, well, we need to reintegrate functionality as a key indicator representing rehabilitation. That will enable us to obtain more commitment tomorrow, more commitment from the different players in the field. Thank you.
Merci, Graziella, pour cette...
Thank you very much, Graziella, for this presentation. That's been very clear on the situation of poly-crisis in which capacity building is necessary to provide care, but also to secure development. We are going to listen to Justine Dambele now. Sister Dambele Justine is a pure product of this cooperation between Belgian universities and schools in Cotonou, in Burkina Faso, and so on, in Western Africa. So she's a clinician at the university, at the Ouagadougou University Hospital. And she's also in the physiotherapy department of the University of Ouagadougou, but she will speak better about what she does than me. Hello, everybody. I'm very delighted to tell you about my career path as teacher, clinician, and researcher for a teaching practice based on, well, evidence. I am the result of that cooperation, as the moderator said, cooperation between Belgium and our countries, Burkina Faso and Benin. You have to know that in physiotherapy, wearing these three caps, that is clinical approach, research, and teaching, really contributed to training competent professionals, to optimizing care and advancing knowledge in the fields of health and education, and to creating a synergy with a view to the permanent improvement of care and the development of competence. And all this through an evidence-based practice with an articulation between scientific knowledge through research and the professional practices. So this is my career path. As you can see, I started in 2010. I got my bachelor's degree in Benin. And that school was set up by the cooperation between Belgium and Benin. I studied for 3 years there, and I got my physiotherapist's degree. Through a partnership then between Burkina Faso and Belgium, I got my master's degree my first master's degree, my second master's degree in Louvain-la-Neuve here in Belgium. And that was then thanks to APFE and Wallonia, Brussels, the Walloon region, Brussels, and the Belgian Development Cooperation Department. And then I did a research work at the Hasselt University, and there was a cooperation between our university and the Hasselt University. My role of teacher in Burkina Faso, in 2020, we set up a physiotherapy school at the National Public Health School in the physiotherapy department. And I teach different classes. There are not many of them with a master's degree in Burkina Faso. So I have to teach many classes. And I did it with a view to transmitting updated knowledge, integrating research, and with a view to developing the credibility and to increasing motivation among students. As far as the clinic is concerned, I work in the National Reference Center for Physical Medicine, Physiatry, and Rehabilitation. That center was set up thanks to a cooperation project between Belgium and Burkina Faso, especially AFP, that plays a major role in our country. And I did rehabilitation on patients with neurological injuries in pediatry and also perineal rehabilitation. And I did it through applying the knowledge stemming from research, through educational communication with the patients, through contributing to therapeutic innovation, all this with a view to improving the quality of care provided to the patients. As far as research work with the Hasselt University is concerned, we worked on identifying the issues in the field. I did all my clinical trials in Burkina Faso, and then I came to Belgium for the analysis. So identification of problems in the field, production of relevant knowledge, involvement of the students in the research work, dissemination of results among practitioners and teachers. And now I'm going to tell you about my research project. So I went to seek in literature what was recommended. So I work a lot with patients who've had strokes. So I went to look in the literature to find about the recommended practices. And we saw that a high dose of rehabilitation is effective after a stroke, with activities, on the basis of activities that are meaningful for the patient. So we went back to the grassroots in Burkina Faso, and we looked at what the physiotherapists actually do in the field. So we carried out an observational study, and we saw that in the daily practice of physiotherapists, the length of time, the duration of rehabilitation was very short. It was mainly based on traditional practices. So knowing that, we built on that to set up a clinical trial. We increased the length of time during which rehabilitation was performed with an active involvement of the patients and their families. And we produced exercises that the patients could perform at home. And we evaluated that. It was really efficient to secure proper recovery of the patients. And the patients really appreciated and were really motivated. And then the fourth stage will be the implementation project and the scaling up to the project to a large number of patients in Burkina Faso. So the initiative illustrates the three dimensions: clinical practice, evaluation of the patients before and after the intervention through validated tests, intervention and involvement of the patients and their families. As far as training is concerned, that is with the students in physiotherapy, we have developed research protocols by involving actively the students. We have evaluated the patients with their effective support. We have written booklets for the training at home, and we included the students in the writing of the booklet, of the manual, and we have also implemented that intervention at the local level. There was the search for practices that were adapted and efficient for the health of the patient, and the clinical research work were published in low-income countries and middle-income countries in magazines or scientific publications and newspapers. So The integration of these three dimensions produce lots of benefits in the patients and in the students, and they are indispensable to secure a proper clinical practice. For example, as far as the patients are concerned, it helps taking into account their beliefs, rights, goals, constraints for a shared therapeutic decision in clinical practice. The patients are at the heart of the treatment. And the impact is a training that articulates theory and practice with the development of a critical mind, critical approach, and evidence-based learning. For the patients, the impact is better care, better quality interventions, and scientifically validated practices, and a more global and humane approach. And as far as the scientific community is concerned, this implies new knowledge being disseminated, contribution to public policies, and international dissemination. Well, our prospects, what we want to do, we want to encourage and enhance the value of mixed careers. That is, professionals which are involved in the three dimensions, the clinical, training, and research ones. Then we want to strengthen intersectoral and inter-actor partnerships, or multi-stakeholder partnerships. And we want to support, we want in the future that a collective momentum and mutually beneficial momentum focusing on the rehabilitation strategy 2030 of the WTO that implies access to the services of high quality rehabilitation, the strengthening of the headcount of professionals in rehabilitation, improvement of data collection and development of research, and the creation of partnerships. As a conclusion, I'll say that a combination of these three roles, teacher, a professor, a clinician, and researcher, is strategically leveraging the development of physiotherapy at the service of the students, the patients, and society as a whole. Thank you for your attention, and thank you very much to our partners. Belgium, really, with DGD, APF, the Walloon region. Thank you so much.
Merci, Sœur Dambélé. Nous sommes donc au terme des 4 présentations. Nous allons...
Thank you, Sœur Dambélé. We're at the end of our 4 presentations.
La deuxième partie de cette session.
Now we're going to open the second part of this session with questions and answers. But before that, I would like to make a small synthesis or wrap up. We have tried so far to show how training can improve access to care. Training, education of professionals is going to care. We have heard in those presentations that being better trained, or training more human resources, more good quality training, human resources can improve the quality of care in all communities overall. If we look at rehabilitation, which we're dealing with now, there is a number of children not having access to school. The last UNESCO report show that on average 50% of the children, sometimes it's 80% of the handicapped children, disabled children, children with disabilities, do not have access to education, no access to schooling, because they do not get proper medical care. They have no access to technical aid to improve their mobility. They have no access to care for to be rehabilitated, and that would enable them to go to class, to go to school. And in that sense, working in the health sector could bring more children with disabilities to school and thus improve the schooling rates within certain population groups. So health educates, but education cares, as we have seen. Now we're going to give the floor to all the participants who are with us now for questions. You'd like to say something?
Une seule minute, c'est juste pour rassurer notre orateur, professeur.
I just want to reassure our speaker, Professor Patrick Williams. He said that in Burundi,
Effectivement, c'est une information qui fait allusion au Sénécaire qui
well, he
était
gave a piece of information about
difficulté de gestion.
Burundi,
Je pense que le Burundi,
and there are management issues. There were management issues, but Burundi is now going through an administrative reform process, and things have been clarified. There is a decree that has just been out and reorganizes the ministries, and now the establishment is under the authority of the Ministry of Health. I think the legal framework is being improved, and each institution will be properly defined and properly delineated. As far as figures are concerned, I think what he said, well, there are certain data. Now I heard that there were only 12 or 14 physiotherapists.
On est sur la même longueur d'onde. Une autre chose, c'est au niveau des aides techniques. Vous avez vu qu'au Burundi,
I think the situation has changed, and
quelqu'un qui travaille dans ce domaine, on aimerait vraiment développer des partenariats avec ça. Je vous remercie.
We would really like very much to develop partnerships to improve our action in the field of rehabilitation. So if you need to ask questions, please introduce yourselves, but speak slowly to facilitate the job of the interpreters. Yes, I'm Pierre Mertens, Child Help. We work in about 15 countries, more in Eastern Africa. I'm surprised to hear that occupational therapy is not emphasized. Our children benefit much more from occupational therapy than from physiotherapy. That's one of the things I wanted to point out. And then secondly, it's a north-south cooperation. We train the neurosurgeons, and the African neurosurgeons provide the training and re-educate the African surgeons, neurosurgeons. And in the future, wouldn't it be good that the South could, if the South could educate the South? We're going to collect a number of questions before giving the speakers the opportunity to answer, but the moderator should speak in his mic. I cannot hear him, for example, now.
Merci. C'est une question très rapide et de curiosité.
Thank you. It's a very quick question. I'm curious about Burundi, the program you presented about Burundi. Why? I was wondering about the sixth pillar concerning technical aids. Why isn't it part of the program? And I wanted to know if there was a particular reason to explain that. Thank you very much for the presentation. It was very interesting. How do you make sure that services are available at the community level?
Alors voilà, moi j'avais juste une question par rapport aux standards.
I have a question about the international standards. I see that the use of university and NGO standards are very often different. Is there some work carried out on the harmonization of those standards in developing countries to foster the harmonization of the standards? I want to start with a saying that says that knowledge is the only thing that extends when you share it. And there is someone here who was not mentioned. And I think that I can say that without her, without him, Mr. Jada, nothing could have been done. My question is about rehabilitation, community-based rehabilitation.
former les mamans principalement à la prise en charge de certains soins.
So, how to support mothers? So what prevents us from training mothers so they can provide certain care to their children, for example, children with disabilities?
Passer la parole aux intervenants. Et puis, bien sûr, certainement que moi aussi, je reviendrai. Je passe la parole sur la question des standards.
About a question of the standards.
Alors, les standards ne sont pas différents.
Standards are not different. Today, we are in an approach of cooperation with World Physio. World Physio is an organization that defines the standards of the profession. When we set up a curriculum of initial training of physiotherapists, of therapists, in Rwanda and elsewhere we've done it, we cooperate with those institutions. When we are in emergency situations with a shorter curricula, there were lots of discussions with World Physio about the status of assistant physiotherapists. They did recognize that even in countries such as Canada, they are professionals, and it's not realistic to ask for 3 or 4 year training courses that cover the whole country in all countries, but we need monitoring and mentoring mechanisms that must be predefined. Nowadays, there aren't different standards between NGOs and international standards because we cooperate with international bodies. We work together. And in Vietnam, it was necessary to start with the analysis of the needs, because nowadays obstetrical fistula doesn't mean anything for us, but in Congo it's a reality in many countries. We should analyze the needs of the countries, and that should be the start of every curricula. We should analyze the needs of the countries in terms of health issues, but also coming to occupational therapists. Well, countries where there is nothing will start with physiotherapists, but if there is no occupational therapist, the physiotherapist has to include wheelchairs. It's not part of the curriculum of physiotherapists in Belgium, but the analysis of the needs will lead to the adoption of the curricula that will be developed. And countries such as Morocco and Rwanda have created a physiotherapist curriculum, and then they have developed a curriculum for occupational therapists. In the ministry, they decided that the 100 first occupational therapists would be hired. They were all hired immediately, but it requires a national commitment that guarantees the hiring of these people. But it's a question of maturity. The question we could ask is, are all countries nowadays able to have speech therapists, occupational therapists, orthopedic technicians, physiotherapists? It's not possible. And we come back to the standards. Aren't we exporting our curriculum models? Shouldn't we propose innovative training models with mixed curricula, maybe occupational therapists and physiotherapists at the same time? And the professional associations are barriers because they defend they uphold their professional interests.
Professor Williams, would you like to say something?
Merci à madame qui a posé la question.
So thank you for asking the question. Why the sixth pillar is not developed as the same as the other? I showed you that we had very few physiotherapists when we started. So we first started working on that. We are trying to see how we can develop it. It asks for some funding in Burundi There is no initiative for local manufacturing of a wheelchair or prosthetics, visual or auditive prosthetics. That's the reason why I called upon anyone that could be interesting to collaborate in that direction.
Au niveau de son programme, en ajout, et je vois qu'il est en train de demander la parole. Il va,
I see that somebody is asking for the floor. I'm sure he will add something. I would like also to say that we forgot Jacques. He is definitely the catalyst of everything that was done in Burundi. For technical aid, APFI specialized in physiotherapy for 30 years. That's quite a large area as such to invest ourselves fully. Now we have a model that works and that was reproduced in Burundi, Burkina Faso, and so on. We never got interested in technical aid, and we will probably have to do that, and the director will probably say that we want to start working in prosthetics, for example, building on Belgian capacities in that area. There are different organizations that are interested in that, and we would like to dress ourselves as well. When it comes to Burundi, there were players in that area like Handicap International or the CICR, but Burundi, unfortunately, has a difficult reality, we can say so, and these NGOs stopped their activities in that area. So at the time being, there is no specialized partners for developing wheelchairs, prosthetics, visual aids, or auditive aids. So we are really calling the organization to get interested in that. It's a huge area that requires a lot of investment. We could work in that as a PFA, but we won't be able to do it all. We need more partners. When it comes to the North-South or South-South cooperation, we are not well, we are started from Benin and we went to Burundi and Burkina Faso. It is what we call a triangle cooperation with the 4B, Benin, Belgium, Burundi, and Burkina Faso. It works quite well, actually. Burundi based itself on Benin to develop school because the bachelor were trained in Benin. And then went to Burkina. So Burkina went to Benin and they came back to work at the national center. Then they went to Belgium for the master studies. PhDs are at the Louvain University or Brussels University. So that's a win-win, really, as the Belgian teachers supporting our students are also learning about issues that are not existing in your country. So it feeds the reflection. We can say that we are indeed in such a cooperation. Then the community training. This is related to the availability. When you have a very few number of physio, like a dozen of them, as it was the case, there's nothing you can do. because you don't have the basic material, the human resources. I think that Burundi have now about 40 centers. Same in Burkina. We are working on the 13 regional hospitals. And with this training, we will have more human resources, more access for readaptation services. This is what I wanted to tell you about community-based readaptation. It is indeed an important topic, but it is also a multi-dimensional. It's health, social empowerment, and in our countries, it is difficult. I know that in Benin, they have a program that works more or less. So you always have that type of discussion. What we can say is that the different countries of the WTO realized that readaptation was key. And they made a commitment. Maybe Olivier will tell more. In Africa, countries committed so that by 2025, 60% of the countries have a development plan for developing physio. It might not be a priority for now in healthcare system. So these are the problems we are facing now. But indeed, with the available human resources, I'm sure we will make it. Olivier, would you like to take the floor? I just want to say why we need readaptation in Africa. Why is there such a need all of a sudden? We didn't talk about that 40 years ago. In the 60s, when African countries became independent, the life expectancy, average life expectancy was 40 years old. People were young, very young, and they did not have the time to be the victims of incapacitating diseases before disappearing. Now, the average life expectancy is 62 and even 64 in Burundi. It completely changed the epidemics of incapacity. People now are living longer and they are developing incapacitating diseases, notably chronic diseases. We talked about strokes. We can talk about diabetes, hypertension, cancers, road accidents. Road accidents are a real issue in Africa with the development of roads. And that means that the needs, the readaptation needs have changed because of the change in the epidemiological profile. In fact, they have nothing because they never thought about that. And now they realize that it is a crucial need. And this is why actors like ours are called upon to say, please come and help us develop our health system. This is why it has become a priority of the WTO. And all countries gathered in Osaka said that we need a roadmap for developing readaptation in our healthcare systems. Okay. We are now reaching the end of our time. It's not a question, it's more of a comment on this program. I was a coordinator of APFE, so I followed this medical readaptation program in Benin. And that time, as I said, I was a coordinator, now I'm in charge of Benin. And I followed Benin and Burundi, not so much the Burkina Faso. But when it comes to that program was for 20 years. It was a long-term vision, and that was very important, and it was pioneering. It was a long-term vision taking into account all type of processes. And I can hear the results today, and these are innovative results, not only when it comes to the curricula, but also the employment. You're talking about mixed careers. At that time, there was already such a strategy, a multi-dimensional one, as it touched upon road accidents as well as nutrition with stroke. So we can see the evolution in Benin, the food needs, the food evolution, the consumption needs, new reforms made by the president when it comes to local consumption and so on. So it's an epidemiological and public health approach. That is for a global approach to healthcare. This triangle cooperation was thought of in terms of mixed and diversified professions, but also in terms of territoriality. We are in Western Africa, and there was a national and regional, cross-regional reflection. It was very important because the South-South issue comes from the needs and the authorities, national and regional ones. So policies are not only decided in the north, but they are negotiated with the authorities of countries. Thank you. Time flies. I think we will have to stop there. I would like to thank all the participants. Maybe a last message. I want to tell you that readaptation is a health right, and it is essential for the social economic participation of these people. The professional training, as we showed, is a pillar for accessing readaptation services if we want to work on endogenous system. NGOs, universities have their role to play, and we need a global dynamic to support the Rehabilitation Strategy 2030. I would like to thank all the speakers, notably Alexia Germaud, and also everyone who took the floor. Sister Dembélé, Graziella, Olivier, Dr. Jean de Dieu, myself. Let's not forget about myself. So thank you everybody for this session. I'm sure we will keep on talking in the corridor. Thank you.